Okay, hello everyone. Welcome to the part 2 of our presentation, which will involve the intraoral examination with otoscope. So, why do we look for lesions? So, this will reduce deaths from skin oral pharyngeal cancer. Yes, there is a chance of death, but when oral cancer is detected early, we can have a significant um, chances of survival. So a lot of time deaths are more in general of depending on if they have access to care, things like that. So if you have a patient that's coming in regularly and they've seen that, or someone who has coming to the dentist for a long time, and you do an intraoral examination and you see something a little that is atypical or a significant finding, we generally want to refer them out to a pathologist just to make sure everything is looking okay. Like we already talked about, early detection and then appropriate treatment and referral. So when it comes to soft tissue lesions, so what are they? So normally soft tissue is just your mucosa, so anything that is abnormal. So we all know what the normalcy looks like for most patients. And I don't like to use the word normal, but a lot of times each person has their normal. But here, anything that looks a little more significant, something a little out of the ordinary, something that doesn't feel right. So generally you want to write down the color, the texture, the form, where it is located. And the reason for that is significant because our tissues in our mouth are generally one of the fastest, like it goes through the changes pretty fast. It regenerates itself is pretty fast compared to muscle and bone. So if there's something is healing, we want to note down the original size and eventually monitor it over time. And that's the number one reason. And second, if it resolves, at least we have an original. If it's getting bigger, or sometimes things just stay the same and they don't bother, but at least you have the current measurements, and everything were to get bigger or smaller, we want to note that down. So normally we use a periodontal probe for millimeter increments or a ruler for centimeter increments, or inches at times, but depending on how big the lesion is. Excuse me. So I will go through, there are a bunch of slides that there are ahead that kind of go similar to the extraoral, which kind of goes by step. But right now I'm going to go over this intraoral assessment with the video with you guys. This video describes it really well. This is also by Hygiene Edge. So when we do any intraoral examination, we want to start off with the lips. That's the entrance point for your mouth. So pretty straightforward for there. Oftentimes we look for Fordyce granules, or canker sores, blisters, pustules. Biggest one is herpes. So canker sores cold sores for a lot of people. We all know that it's important to know that if there is a active HSV1 viral, then we want to make sure that the patient is brought back within 2 weeks, or depending on how long it's been. If it's been a couple of days since they had the active infection going on, then give them 2 weeks, because it can spread. So if there is like a big like an ulcer here, then you want to note down the size, and when they come back in 2 weeks, then you want to see if it's gotten bigger or smaller. Some people have it as a nodule, so things like these are important to know just to see how severity of it is. So that's why we start off with the lips, right? So if there is anything going on here, then we will be like, okay, we gotta start treatment, and we'll rebook you back. So that's important to start from the lips. So now she's just kind of picking up the labial mucosas and seeing if there's any bite marks around the lip. So right now she's just kind of skipped ahead pretty fast there, but right, the labial mucosas, you want to see if there's any lip biting. Like a lot of patients go this a lot. They really put the emphasis on there. Sometimes they had something spicy, or again, cold sores, canker sores, things like that. They can get a canker sore there. If they bite their lip also, and then up here as well. So it's pretty common to have those kind of things. So let's start off with there. Be gentle, obviously. I think this is a more speed up video, so just kind of look around slowly, take your time with it, and then you'll just want to go for the buccal mucosa there. So generally in the buccal mucosa, we look for the linea alba a lot of the times and see if there's any cheek biting marks. Some patients have it just starting to heal. Some patients just had it. Some have canker sores, ulcers, things like that again. So we want to note down those things. So linea alba is usually a sign of like clenching and grinding. It's not an oral cancer screening, but it's also a good assessment for you as well. So now she's just palpating by digitally, so she's just kind of feeling if there's any like stiff parts of your mouth there. So if there's anything that's like a nodule there, you might want to feel it and be like, oh, okay, that's something on. How long that's been there for, ask those kind of questions, and then note down the size, how it feels, is it firm, tender, non-tender, movable. If not, then monitor it for 2 weeks and see if it doesn't get any better. So same thing here. So you're also kind of doing the mucosa here as well on the inside and outside by kind of going in like this. So she did skip pretty fast there. So yeah, so you start from the cheeks, and then you would ask them to, she went a little ahead with the tongue part there, but you would want to start off with wrapping the tongue with the gauze, so you can pick it up underneath it. Pick it up, feel for any weird salivary stones sometimes, or if there's a bite mark there, ulcers, things like that, just so you're aware, and then you kind of see if there's anything free-flowing with the saliva as well, and then you want to check the sides of the tongue. So you can see, just checking the lateral borders. A lot of the times we see the signs of oral cancer around the tongue and the buccal mucosa, so it's important to notice anything that's atypical so that you can make a note of it or send out to oral pathologist. So she's kind of checking around the 3/7s or the 4/7s to the 4/8s. So now she's checking the floor of the mouth. I think this step we kind of miss half the time. So she's really, because we tend to forget the floor of the mouth has a lot of space. If you have even a consider a normal mouth, if the person doesn't have a big tongue or things like that. So it's important to kind of go in there because it can be salivary stones, or it can be an ulcer, it can be a spot someone uses for chewing tobacco, so they might leave it in there, so it might be a lesion there, so it's important to keep an eye out for that as well. So for right now, she's just taking the saliva and a sublingual carbuncle. Sometimes I have it at times that it just sprays out and actually goes on the patient's face and they don't even realize it. So now she's checking the parotid papilla as well, checking the saliva, and here, so that she just to recap that, checking the entry points for your saliva and just to see if it's free flowing or not. If it's not, then that's something to kind of definitely note down. Maybe they're experiencing dry mouth, another risk factor for oral cancer, just because if there is dry mouth in that area, increases for cavities, things like that. Or if they could be the cancer in regarding the gland, we're not sure, right? So I had a patient not too long ago. He had oral cancer actually, and he had it more in the parotid gland. So when he had radiation therapy, everything was more directed to his side of his face. So he has a lot of scar tissue now actually. So he has a very difficult opening and closing at times. He has a very limited, so things like that. So it's important to note those things, that oral cancer is just not related to chewing tobacco or things like that. It can be from just genetics as well. Now they're checking the oropharyngeal areas, checking the uvula, checking the hard palate, things like that, seeing if there's any burn marks, bite marks, things like that. They're canker sores at the end of the day. So that was a pretty good video, and I think that this speed this up compared to the old one, but good reference point to keep an eye out for there. So now we're going to talk the Velscope. So now that you've done your intraoral, extraoral, intraoral, and the last step is the Velscope. So we all know that the Velscope is a great tool to use, especially because it does go see precancerous lesions, and it doesn't confirm it's cancerous, but there is a way to have a better chance of detecting it. So a lot of the times that I have I know hygienists don't have a lot of experience with it, so this is a great video to watch as well. This is by Hygienist. You should really follow them because they have a lot of great videos to follow along, which have great tips and techniques. So I'll kind of go over this with you here. So the Velscope comes with a few things. So it starts off with the actual Velscope itself. It has a charging station, and it also comes with a wire, so if the charging port doesn't work for you, you can use the wire as well. These are some protective glasses just due to the fluorescent light. Glasses for yourself, and then a barrier you put on where the light will come out, so just more infection control. And then it also comes with a sleeve barrier that goes over it so you can wear your gloves, and then when you do use the disinfectant, you're not just wiping everything with disinfectant, so it's just kind of a lighter disinfectant there, just like you use for your section. So that's what this comes with. So it's a one important thing is to mention is that it's not a diagnostic tool. Anytime cancer is detected, it is sent to an oral pathologist and you need to do biopsy or you need to do further testing. This is just to see if there is any lesions that seem a little untypical, and then we want to find those findings and send them off to a specialist. So she's just kind of showing the thing there. So this cap is actually very easy to use because it actually really clicks on really well. So it has those grooves on there, which allows us to clip on easily. So you can see that there, and the blue side is outside. So you can kind of, good markers to see the blue on that side and the blue on this side. And then it clicks on there, so that's pretty good. So that's the barrier I was talking about. So the barrier has this weird little two holes coming out. So the whole point is that the middle part like that is covering the middle, and then you have the two camera sides there. And you also want to make sure that the barrier is not covering the exhaust points, just because you want the heat to escape, and it is plastic barrier. And so they're just kind of showing in the on and off button right now. So you can see that it's showing that it's being charged at the moment, and then so that's just showing on and off, how it turns on and off. For me, I've always used the wire connection one, so this charging stand, not really. But I mean, it is definitely a plus point, so you don't have to connect the wire. But it's awesome to just pick it up and go, whoop, ready to go. They're just kind of going into detail and how it works. So it does overheat, so make sure those exhaust points are open and not covered by the plastic, so it can release the heat. So you'll lay your patient down, make sure you give the orange glasses in so they can protect their eyes, and obviously you'll go through the MHDH and extraoral if they have a history of using tobacco for 15 years, they never had a proper dental checkup. This is a great opportunity to use a Velscope on just to see if there's any lesions that seem that are a little fishy. It's plaque for the better word. And you want to hold it 8 centimeters away, so I mean, you don't need to be so exact on that, but like generally you can't fit this whole thing inside your mouth, so just kind of dragging along. You can actually take really good pictures. I've had a hygienist take some good pictures through the lens point there. Make sure you protect your eyes from the blue light obviously as well, but try to so through there, like she's saying there, and you might see some black lesions, and those are the parts that we want to notice. That, oh, note this down. Where is it? The area? Is it on the dorsal of the tongue? Is it on the left buccal mucosa adjacent to the 2-7 or 3-7? So you really take your time with this, and if there's anything that does look a little fishy, then obviously wait the 2 weeks, see if the lesion heals. If not, then refer them out bring them back for a follow-up appointment and refer them out for the necessary referrals. Like I said, you don't want to advertise this as a diagnostic tool. Oh, you have cancer. Never say that to your patient, because at the end of the day, it can be something else and we're unaware of. So make sure you just say, hey, like, I noticed that you have history of using tobacco. I find that I want to use this, lack for a better word, is like a camera or a screening tool, just to see if there's anything that's lesions that are a little bit out of the ordinary. And if I find that there's something out of the ordinary, I want to confirm with my dentist, and either we'll book you back in 2 weeks to reevaluate, see if it's getting any better. If not, then we'll refer you out, and then we'll get a better idea. Obviously, you want, if there are to be smoking and things like that, you want to do your smoking cessation, talking about the tobacco use, marijuana use, and even some people don't realize that your mouth absorbs a lot. So if there is anything going on there, it affects the rest of your body. So this is a great video as well. So look through it, watch it, enjoy it, and I think you don't really need a training course to really understand how Velscope works. Just use this, and I think this summarizes it really well. So go ahead with this here. Okay, so I'm gonna go back actually. So I just want to go over a bit of skin cancer and cancer in general, just because it's something we don't really talk about once we leave hygiene school. So we do have a few dental hygienists with us today. So it is the most common types of cancer, just because, hello, you have skin literally everywhere. And a lot of the times we forget skin is an organ, so we tend to and it's one of our strongest, most protective barriers as well. So it does take a lot of the beat and heat. So in US, we get diagnosis of 1 million diagnoses yearly, which is amazing to consider that these people are actually finding early detection. That's another ball game. And then, like I said, if it is in the early stage, we can cure them and treat them. That's the best part of all this. So there are two main types, the melanoma and the non-melanoma. We're very aware of those types when we were in hygiene school, so let's go over a little bit of that. The melanoma is more likely to spread other parts of the body, so for usually the biggest one that we all know of, and a lot of the time something that it's hard to detect as well, because we take it as pretty nonchalant, and we're like, oh, that's just mole or that's something there. So that's why we do the external exam and the intro exam, that like it's so important to be part of that. So and like I said, if it's treatable if you caught early, but if it's starting to spread to other parts of the body, it's hard to manage and hard to treat as well. So early detection, guys, early detection. So this can just look at here, that's an example of melanoma. And I mean, if someone has darker pigmentation or in their body, or if they're more darker skin and something like this, it's harder to detect really. And we're not educating our patients enough to realize, oh, something like this is not normal, so we should keep an eye out for this and maybe have them talk to their doctor. So the non-melanoma is another example. Yes, is another common cancer. Nice thing about it doesn't spread to the other parts of the body and less fatal. So that's nice to know, that there is something like that out there. But I mean, cancer is still cancer at the end of the day. So the basal cell carcinoma, I don't like looking at pictures like this for some reason. Like, this freaks me a little. But what I will say is that when you do see something like this can look like any regular papule. It can look like any regular pustule as well. You'd be like, hey, like, how long you've had this before? Oh, I've had it for 5 years. Oh, okay. Have you had it looked at by anyone? No, not really. I thought it was just normal. Like, who knows, right? It's cancer right there. And well, you can't say the word cancer to your patient. You just say, hey, this doesn't look right to me. I would rather have you get it checked by your dentist, or we can refer you out to a pathologist. Maybe check that out, make sure everything's looking okay. Don't scare your patients, because cancer is a very scary word. So don't use words like that. Have them say, hey, this doesn't look right to me. This seems a little out of the ordinary. I want to be extra cautious. I want to be a little more proactive. These are the words you want to use. At the end of the day, you don't realize that you're not allowed to diagnose. So don't say words like cancer. Um, and if it ends up being nothing, great. Honestly, God's to great. Then they'll be like, oh, thank you for being so thorough. Like, I didn't have anyone go be thorough like this, but, um, or if it did turn out to be something more serious, then you're like, oh, thank you. My dental hygienist told me something was wrong. So we are actually in a win-win situation regardless. So things like this, keep an eye out for. Another example here of the non-melanoma. This is squamous cell carcinoma, and this can look, if you look at this clearly, this looks like someone got punched in the face, and they just have a crested lip. If you really think about it, like if someone who wasn't educated in all this, so that's why it's important to note down this. And if you saw this in your patient, like, hey, what happened to your lip? I don't know, like this, I don't know, like I have so much going on in my life. Okay, you know what? Oh my god, I forgot to mention this. When you work in private practice and you're allowed to have a camera, take a picture. You know, like pictures speak a way more. I mean, you should note down the size and with a ruler, things like that. And um, the idea behind that is like if you're working more rulers, you don't have enough sources, then obviously you should note it down. But when you have things like a camera, take a picture of it. And when they come back in 2 weeks, then you can be like, oh, it actually looks a little better. It's healing, things like that. Or if it's not changing at all, then you're like, hey, I think we should get this checked out. So use pictures, guys. So this is just a nice table to kind of look at, sort of summarization of everything. The last thing we did was the Kaposi sarcoma. Um, this can just look like regular pigmentation. That's really interesting, right? So, like because the color can be intense red, blue, and brown. So color does not blanch. So that's interesting to look at. So that can look like someone who's a little more brown in skin and color. It can be just normal pigmentation, or it can be something more serious. So 75% of head and neck cancers originate in oral cavity. Well, entry point, your squamous cells, things like that. So your highest level there. And a lot of the times is the risk factors. You're consuming smoking through your oral cavity, well, not consuming it, but inhaling it. It travels in your oral cavity. Alcohol you're consuming, HPV. If they're not getting vaccinated and they are sexually active, it is a concern. Sun exposure, obviously it's not, you're not opening your mouth looking at the sun, but it does pierce through, especially the skin, right? Skin cancer. So that's something to definitely look at. And another thing is that 1/4 occur in people younger than 55. So 25% of the population is a risk factor. Under 55, we can't always say, hey, I'm 20, it's not an issue. You never know. You could be part of the 25% of the population, and it is difficult to manage. And um, having things like talking about cancer at such a young age, it is very devastating to the patient as well. So, gotta keep that in mind. So these are some kind of common areas, and I would want you to kind of take this seriously. The lower lip, you know, this is why we start with the lower lip, guys. Close to 40%, and then on the tongue, 30%. That's like 70% right there. And the rest of it's like the floor of the mouth, which is why we do the kind of going inside the floor of the mouth and checking there. So that's 14%, and then the rest of it's just on the soft palate, uvula, things like that. So it's important, excuse me, it's important to realize that it just starts really right there, and I think skin cancer is the biggest on the lip as well, so keep an eye out for that. There's a nice table to kind of say, like, what are some signs of oral cancer? So patients can say, I have soreness, I have ear pain, I have difficulty moving my jaw, um, something's off. Can you check this out? Honestly, God, like any symptom, you should take it seriously, take a look at it, see if it doesn't heal within 2 weeks. If it doesn't resolve, you get it, go send them to a pathologist, get it confirmed. I can't repeat this more and more. You're not the doctor, you're just there to note these things down and be like a chain of responses, and because you are given this responsibility because you are actually seeing patients more on a daily basis than regular doctors or specialists. Cancer signs. There's a list of cancer signs. I mean, it's good to know, but it's not something you would want to obviously have to memorize all the time. So extra information there. So like I said, your role in all this. You examine it. Hey, there's something off. Okay, so do you use tobacco or alcohol? Yes. Oh, do you know that when you use tobacco and alcohol combined, it does increase your risk of oral cancer? Oh, I did not know that. Well, there you go. You educate them. You do smoking cessation. You do um, just in general. Some people just use tobacco only, so you talk about that. So you do your whole states. Are they in relapse? Or are they on non-agreeable states? They don't want to do anything about it. They're educated. They know the risk factors, things like that. And then you would talk about do your external internal examination. Then you're like, oh, this looks odd. Take a picture, guys. We really should use our digital cameras. Take a picture of it, see what it looks like, and from there, have them come back in 2 weeks. Even just with you, like in private practice, you have a lot of liberty, and even in just your school as well. Like, if you have a patient that's coming in every week for a cleaning and or like for your checkup appointments, you have 8 appointments with them in hygiene school. When you bring them in 2 weeks, at least you can see if it's getting monitored or not. And even in private practice, don't feel bad for booking the patient back in 2 weeks. I have done it where it's not no cost to them. But at least you can see you have the uh, what is the right word? You have this assurity in you that you did your job and you made sure things were following through. And it is your job at the end of the day. It is your responsibility, but also a mental like assurance in your head, like, hey, I thought I saw something, and oh, good, we got this done with. So usually, depending on what kind of lesion is, we refer them out. Um, dermatologist obviously for skin lesions, so extraoral lesions, and then intraorally we usually want to send them to a surgeon or a oral pathologist. And make sure you get their follow-up report as well. I think I can't stress this enough that a lot of the times patients get referred out. Either they don't end up going there, life happens, their thing is not necessary. So it's so important for you to educate and say, hey, I'm referring you this is for a reason. I want to report back from them as well to just make sure everything is looking okay. So this the part here, this is very important, and you really need to educate this to your patient and be like, I want you to go here, please go. I am telling you for a reason, please go. And I think at the end of the day, this all comes down to education. If you don't educate your patient, they're not going to care. They're not going to find the importance. They're not going to find the value. So these are just examples of soft tissue lesions, and anything that can be allergic reaction can be sign of hives, injuries, blister, scar, birthmark, things like that. I'm not going to go into too much detail about everything here. These are some good points that you can look into. So they're just gonna go over the traits, and like I said earlier, this is a reference for you as well. Take this, print it out, put it in your binder, things like that. This is just gonna go over it. This is called the regular border. So regular is just it's a circle, pretty easy. This is irregular. So this looks like someone might have had a cold sore. I can't make a diagnosis obviously, but from looking at a picture, but this might be a cold sore, and usually there's like little vesicles to them. So you're gonna want to note that down if it's regular or irregular border. So is it a smooth margins? So is it raised? So you want to note things like that. So this is a red and white lesion. So this can be risk actually a couple things. I've had patients who they had no tobacco use or anything, and then they're like, oh, they've been biting their cheek a lot, scared nice tissue, or actually they had stuffed their tobacco in there. It can be multiple things. So it's important to note this down, take a picture of it, write down the measurements, and then have them come back. This one, blue lesions. I see this a lot with older patients. This is definitely something common because they're on blood thinners, even like baby aspirin, and over time their tissues aren't as strong. They don't, um, even their connective tissue isn't as strong. So what happens if they bite their cheek and it actually is so severe that it creates these blue marks like this, and it's like a little blood clot in that area. So it does take up to a couple weeks for heal. So um, this is important when I see in elderly patients as well. Not that it is not in younger patients, but this is definitely I see once in a while here and there. This is just more information on the configurations. Are they together? Are they clustered together? Or are they separate? Um, because I mean, you can't sit there looking at this tongue and note down every single little macule that's on the tongue. Though you won't even. You have 1 hour with the patient. You gotta think about this. That this you only have like 5 minutes when you're doing all this in private practice. Like you don't have the luxury of when you're in hygiene school where you get 2 hours to do everything. So you have 5-10 minutes you're doing all this. So just realize you're like you just have a checklist in your brain. You're just going tut 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 done or not. Oh, this is an example of group configuration. Are they together? This really looks really nasty. Oh my god. So I'm not gonna go into detail with you guys. Please reference this. This is for you to watch. So lastly, it's important to have a sequence. So I don't know if you remember this, but A, B, C, D, T. So A, the location, B, the border. So you say location would be if it's on the outside, you'll be like the parietal region, the temporal region, the mental region. If it's intraorally, you'll be like the buccal left buccal mucosa adjacent to the 2-7, 3-7, or if it's on the lip, you'll say the lower lip towards the midline, things like that. So location, border, irregular, regular border, color in the configuration. Is it a black region, red, blue? So note down the color dimensions, and usually you have a ruler or a periodontal probe nearby, and then you measure in millimeters or centimeters. And if it's like a papule, then obviously you have 3 dimensions. If you have a macule, then it's 2 dimensions. And the texture, you can note down if it's raised or if you can say it's smooth, things like that. So those are a couple examples. This should be pretty standard on how you note down your notes. So anytime you see something irregular, your A, B, C, D, T, this rule you want to follow for external and internal as well. So for this one, an example would be on the gingiva of the, I forget what side is this. This is 3233. There is a regular border, pink, pinkish in color with brown pigmentation. Dimensions would be, let me take a quick guess, it's the size of a tooth, so maybe centimeter by 0.5 centimeter. Raised nodule, papule, I can't say for sure, but that's a way to describe it. So there's a couple of practice activities as well, just to kind of go over it. So this is another one as well. So this would be a cluster together, obviously. So you would say on the upper lip, on the left hand side, pinkish red in color, dry, is very dry, whatever works. I'll measure it. You can do the cluster together, so you can say whatever, millimeter by millimeter. It could be 6 by 7 by 0.5. It's a cluster, raised, irregular border. Lastly, this is pretty straightforward as well. You can just write, actually this one you can write near the labial commissure, interorally on the labial mucosa. You can even write adjacent to whatever teeth it is. It's raised, regular border, white in color, obviously. It's a nodule or a pustule. I can't tell what it is. It could be a fistula, I'm not sure. But yeah, that's an example. Here's another one. We already kind of went through this. So this is my presentation for the Veloscope and oral cancer screening. I hope you guys learned something today. My presentation was more over just a kind of good overview and quick idea on how to incorporate this in your daily practice and things that you want to look out for. The more you do it, obviously, the faster you'll get at it and the more experience you'll get at it. So don't mitigate this. And if you're looking for more time in the dental hygiene practice or in your private practice or wherever you go, if you want more time for these things, please go ahead and ask for it. Be like, hey, I want to do a full cancer checkup screening for every patient I see. Then I want to have that extra time. And a lot of times the Veloscope screening and cancer is chargeable. You can charge these things, and a lot of insurances actually cover them. So this is actually a great, you can talk about it. And it's not even that expensive. I think it's, correct me if I'm wrong, but I think $50 to $60. So that's a great plus point for a lot of people. So please educate them, say why it's so important, and educate them on smoking cessation. If they're noticing that their risk factors is one of the bigger things. If they have a family history of oral cancer, talk about these things. Let's do a screening for you. And use a screening tool. So, and the videos I described today, I think they really break it down. And I wish I had the opportunity to show it to you in person. I think that's a lot more fun than sitting for an hour and listening to me. So, thank you for listening. And please do the evaluation tools and survey, and let me know if there's any feedback on whatever I presented today.